where she manages projects that advance community servings, coalition building, research, and policy initiatives at state and federal levels. She holds an MA from Tufts University in Urban and Environmental Policy and Planning and an MS in Food Policy and Applied Nutrition. Prior to community servings, Hannah has worked with community-led food, agricultural, and active transportation initiatives, as well as for the city governments of Boston and Cambridge. We are so excited to have you here tonight. Thank you for joining us, and I will pass the floor to you.
Hi, thanks very much, everyone, for having me here tonight. So I'll get started. I have a slideshow for everyone, but as I think was mentioned in the chat, I am very open to people interrupting me if you have questions. So I welcome that. I'll pause throughout, but also I think if you have a question in the chat, someone will alert me to that. So I welcome not speaking at you for too long. So as mentioned, I work for an organization called Community Servings, and Community Servings co-leads a coalition called FIMMA, or Food is Medicine Massachusetts. So tonight I'm going to focus on the work that FIMMA does in the food and nutrition and healthcare space. Okay, so just some basics about what our coalition does. So we are a statewide coalition, and we work to enhance the connection between the food and healthcare systems, basically. So we have over 200 individuals who represent over, I think it's like over 90 organizations at this point from throughout the state, and those organizations are community-based organizations, healthcare payers, insurers, researchers, advocacy groups, government agencies. And so as was mentioned, Community Servings co-leads this initiative with the Center for Health Law and Policy Innovation at Harvard Law School. So I'll say a little bit about the history of our organizations, because I think that sort of sets the stage for what we bring to this coalition in terms of leadership, but also kind of where some of the values and are coming from for this coalition. So Community Servings, we are a meal provider for people with critical and chronic illnesses who are too sick to shop or cook for themselves and don't have the resources to get food otherwise. So we got our start in the late 80s, early 90s, and we were primarily serving the HIV/AIDS community in Boston, where the main reason that people were dying is from AIDS wasting syndrome, which is where they just couldn't get enough calories in, and the whatever drugs were out there to help deal with the virus you had to deal with very precise timing of eating and so forth. So in that case, it was like a very critical intervention to actually just provide someone a meal. Since then, we serve a very diverse array of illnesses. HIV/AIDS is still one of the very primary groups that we serve, but also cancer, renal disease, diabetes. So people with very complex health needs, which also translate to complex nutrition needs. So all of that is what we address through food. And the Center for Health Law and Policy Innovation, or CHLPI, they also got their start with basically doing advocacy and around healthcare, also around the AIDS epidemic around the same time. And since then, they've sort of become Community Servings partner when it comes to healthcare policy and research. So we've worked with them on a number of different projects, and so FIMMA is sort of one of those that we co-lead with them. So Food is Medicine Massachusetts came about as a coalition to implement the Massachusetts Food is Medicine State Plan. So the state plan goals were to, for one, to assess the current need for food as medicine services across the state, as well as to what the current access of those programs look like. And so this came about after a pretty extensive 2-year data gathering process. And after that, the state plan, we wrote that, and then it created a sort of a plan or a blueprint for what a healthcare system would actually look like that does recognize the connection between the food system and healthcare. So I will pause and ask a question to the group of what do you think food as medicine is, and what do you think that looks like? It doesn't have to be how we define it, it might just be the sense of how you think of it.
Maybe some type of healthy food that you eat that solves a problem, like kale, I don't know.
Maybe is it seeing like what nutritional deficiencies someone has and making sure they're eating foods to solve those?
Is it potentially if there's something that could be solved by diet as opposed to, medicine, like get you on this program, you can stop taking X medication?
These are all pretty spot on. Any other thoughts?
I guess I'm just wondering how you're probably going to tell us how you figure that out. I mean, yeah.
So I will dive into that next, in fact. So we've developed what we call the Food as Medicine Pyramid, and that is to help really rein in the focus of what we mean by food as medicine. So there are 4 types of programs that we call food as medicine programs, and those are the first 4 tiers on this pyramid. So these are all programs where it's not just a food insecurity program, but there's some sort of connection to healthcare, or there's a much stronger nutrition component of that. And so you'll see that the programs towards the bottom of the pyramid are more of the, they serve a little bit of a broader population, and they're also on the prevention side, versus something that's at the top of the pyramid that serves maybe a more narrower or focused population that is more of a treatment type of program. And so at the bottom of the pyramid, we include programs like SNAP or food stamps. WIC, HIP is the Healthy Incentives Program, which is basically a program throughout Massachusetts where people on SNAP can have their SNAP dollars doubled when they go buy fresh produce from certain farmers and vendors. So all of those programs we know are super essential to health outcomes. However, since they are so broad and don't have that necessarily that healthcare connection, we don't call them food as medicine programs, but they're still foundational. They're still obviously foundational to health outcomes. So that's why they're still included on the slide. And then also the first 4 of on the pyramid here, those are the ones that we prioritize for healthcare funding. And so that might mean, you know, a specific healthcare plan, but in terms of policy, that actually means advocating for Medicare and Medicaid to cover these programs as part of Medicare and Medicaid plans. I can get into a little bit more later about what that actually looks like if people are curious, but it's something that Community Servings, as a medically tailored meal provider, has been doing for the last maybe 3 to 4 years or so, and it's something that we're seeing a lot more energy towards, and it's very exciting as it means a much more sustainable way of funding for these programs. So next we'll go into just diving a little bit more on what these programs actually look like. So what is a medically tailored meal? The FIMMA as a whole, we developed these definitions. So I won't read those out loud because they're a little wonky, but I put them on the slide just for reference. But the basics of what a medically tailored meal is it is a home delivered, ready to eat meal. And it's for individuals with medical conditions who are not able to shop or cook for themselves. And what is really key to a medically tailored meal versus, say, like any other sort of meal delivery, is that the meals are customized to an individual's dietary needs. So it's really key for someone who's managing diabetes, where they have to watch their carbs, but also they might also be going through cancer treatments and have nausea all the time and need to be able to find something that they can eat that actually manages their nausea. So these are very complex diets, and it's something that only a registered dietitian can really be able to create a meal plan specifically for that person. So a medically tailored food package is similar to a medically tailored meal. The main difference being that instead of a ready to eat meal, this type of program is a bag or a package of groceries. So the food itself is still customized to an individual's medical conditions, but that individual is still able to shop and cook for themselves. These programs are often available from food pantries. There's one at Boston Medical Center that's been around for a little while, where where the people can go to the on-site food pantry at BMC and work with a registered dietitian to get a bag of groceries that helps them manage their diabetes, for example. So a nutritious food referral, these are often known as produce prescriptions. And so these programs are often some sort of prescription or a coupon or some sort of healthcare referral, which is really what a prescription is, for free or reduced price healthy food. And so these are given by healthcare providers to their patients who are at risk for chronic illness. So this is sort of the inflection point on the pyramid where we see that this is maybe a more preventative type of program versus a treatment type of program. And then the last category of all of these is a community level nutritious food program. These programs often serve the widest population, and so it's a food nutrition program that's available to anyone in the community, meaning that an individual doesn't have to eligibility isn't on the individual level, it's on a population level, and the reason why that whole population is eligible for this program is because that whole population is at risk for food insecurity and diet-related disease. So these programs are often organized by both a community organization and a healthcare provider together. And so some examples of these might be a mobile food market that's located at a community health center, or it might be a congregate meal program, which is a meal program that is like a sit-down meal for, they're very often used by elder services agencies. That is created by a nutritionist. So, these are different types of food programs that might sound similar to a food pantry and so forth, but what is really key here is that there is that healthcare connection. Any questions about all of those definitions and everything before I move on?
No, I volunteer at Healthy Waltham, but I don't think they actually have a nutrition piece. But everything we give out is fairly nutritious.
Right. Yeah. So there's definitely there's a ton of organizations out there that are doing work like Healthy Waltham of providing generally healthy foods for a community, and sort of those programs are obviously doing a lot of good for the community. And so I think the real difference for what these food as medicine programs are is that there's more of an intent for serving a specific population or a specific or an individual who has a specific nutrition need based on their risk for or experience of illness, and also the food insecurity connection is part of that as well. All right, so I will dive into some of the things that FIMMA has been working on lately. So as I mentioned before, FIMMA created definitions and standards of all of these types of intervention types. This was really important just because when we were doing the state plan, we knew there are all these programs out there and there really wasn't a consensus on what category fell into, what program fell into what category, what the definitions were of that category, and all of that confusion is really a barrier to access to these services. So we, as a whole coalition, reached a consensus on what those definitions were, and also created some program standards for each level of the each food as medicine program type. On the policy level, when the food as medicine state plan was created, we launched the plan at an event at the State House in June of 2019. And through that that's really also what launched sort of all of our legislative relationships today, which has been really great. One of which was with Representative Denise Garlick and Senator Julian Cyr, who introduced a bill in the Massachusetts legislature that we're calling the Mass Health Food as Medicine Pilot Bill. And I'll go more into it later, but this was a really big accomplishment. So they introduced that bill during the last legislative session and reintroduced it again this session after last session, everything kind of ground to a halt because of COVID. And so a large part of this legislation is a research pilot. So our coalition created the model research design for that pilot. In other policy world, our coalition has also created an advocacy agenda that highlights our advocacy priorities, as well as the different actions that we're planning on taking throughout for each of those opportunities. Some publications and reports that we've put out, one was on oral health and nutrition, another being on food as medicine for high-risk pregnancies. We've also created mapping resources on food as medicine for adults with disabilities, and a research guide for community-based organizations. So some of that work is just diving a little bit deeper into food as medicine for even more specific populations, such as high-risk pregnancies or adults with disabilities. So what we're working on currently. So there's the whole FIMMA coalition, and then we also have 3 task forces that do a lot of the work. So as a whole, our coalition is working on two main things, one being a inventory of food as medicine programs across the state. We're hoping that this inventory is something that healthcare providers use to refer their patients. And, you know, the actual design of the inventory, we're not sure what form that's going to take yet, but in the meantime, we're doing a very massive data collection to learn more about what programs are across the state. On the advocacy front, we are advocating for the food as medicine, or the food and health pilot bill that I mentioned before, as well as Massachusetts 1115 waiver, and I'll get into those more later. And then on the task force level, there are 3 main goals or activities that we're engaging in, one being nutrition education for healthcare providers, the second being supporting and disseminating research, and third being expanding equitable access to community-based food as medicine services. So the food as medicine inventory, so as I sort of mentioned before, the goals of it are to improve knowledge of and access to food as medicine programming. And then also to, since this inventory will go beyond just who is already a FIMMA member, this will also work to build a network for dissemination of opportunities or information. And also will work to highlight programs that are specifically catered to certain populations, such as older adults. So we're currently in the data gathering phase, and that's going to be going on for, or we just launched actually the data gathering phase. So we'll be working on that for quite a while. So the next piece of the big advocacy that one of the big pieces of advocacy that we're working on is the Massachusetts Food and Health Pilot Bill. And I apologize, I realize that these bill numbers, the SD 1547, those are actually out of date, but so if you're Googling them, that's the only reason I mention that. So this bill would really create a statewide food as medicine pilot program within Mass Health. So Mass Health is the Massachusetts Medicaid program. And so this program would test the ability of a healthcare system, which might mean a hospital, for example, who offers a whole spectrum of nutrition services. So there have been lots of pilots for, you know, what happens when a hospital provides medically tailored meals for their patients, or when a hospital provides produce prescriptions for their patients. We haven't really seen any sort of research that looks at what happens when a hospital has all 3 available and knows how to assess individuals' needs, basically to triage, you know, who needs what type of intervention, and has the infrastructure to screen people for those services and refer people to those services. So individuals who are enrolled in this pilot, their eligibility will be being food insecure, as well as having one of a number of diet-related diseases such as diabetes, renal disease, or heart failure. And so since this is a pilot, a research pilot, evaluation is a really large component of this legislation. So some of the outcomes that we're measuring are healthcare costs and some healthcare utilization metrics, such as emergency department visits, hospital admissions and readmissions, pharmacy costs, as well as some non-clinical outcomes. So the overall goals of the pilot are to evaluate the impact of offering this whole spectrum of services within one healthcare institution. We're also hoping that this pilot will expand access to these services across Massachusetts. And then logistically, we're hoping that this pilot will improve healthcare systems' ability to provide these services based on patient need. Any questions on this bill? Great. So the 1115 waiver, this is the other big piece of advocacy that we're working on. So this is sort of the intersection of state and federal healthcare policy. So there's the Center for Medicaid and Medicare, or CMS, and basically Medicare and Medicaid statute will say what all states must do for their Medicare and Medicaid programs, because, for Medicaid is administered on a state-based level with the statute from the federal government. So a state can purely just use what is in the federal statute for Medicaid. However, there are tons of what are called waivers, which are what the state can use to apply to CMS to change their Medicaid program slightly. So the 1115 waiver itself is a demonstration waiver, meaning that Massachusetts Medicaid is going to apply to do some sort of demonstration, some sort of pilot program, and they're just they're getting permission from the CMS to do that. So the 1115 waiver specifically was the first one. Gosh, I don't remember what year it was, but this is currently in 2021 is the renewal of the waiver. That was the last waiver authorized Mass Health to create accountable care organizations, or ACOs. And so loosely speaking, ACOs are regionally based healthcare systems that are both a healthcare system and a healthcare payer together. And they often have a different paying structure, where it's not a fee-for-service pay structure, which is where a doctor will get reimbursed for each service that they provide. And so they have incentives to provide services with a different payment structure. The healthcare system is given money per member, and they have just a certain amount per member. So there isn't any sort of incentive for doctors to do certain. The incentive is really just to overall keep members healthy, basically. So that second type of structure gives healthcare providers a lot more freedom to do different types of more social determinants of health type of services. So, sorry, that was just like the giant healthcare 101 that I tried to stumble through. But the 1115 waiver, something that also happened in Massachusetts, is that it authorized and provide funding for a program called Flexible Services. And Flexible Services provided dedicated funding for nutrition and housing supports for Mass Health members. So this Waiver generally is something that we're very involved with in terms of advocating for the flexible services program to continue and hopefully to increase in terms of the funding available for it.
And how many people will the initial pilot serve? Do you know?
That's a good question. We don't know. I think it's tricky because the loose amount that we were hoping in terms of just having a pilot or a research that has, you know, statistically good numbers, a good sample, we were thinking about 1,000 people. But that said, something that our organization has always been committed to, and similar other organizations, is to provide food not just for the individual but for the family. So even though it might just be 1,000 study participants, we're also trying to build into this study structure to also include their family members.
Oh, that's awesome. Thank you.
Mm-hmm. Okay, so some of the ways that we've been involved with this 1115 waiver advocacy is submitting comment letters or encouraging FIMMA members to submit comment letters to Mass Health. And our coalition also created a comment letter that we sent to Mass Health last month. Once Mass Health actually releases what their waiver renewal application is to CMS, we'll have the opportunity to comment on that as well. So and that will be sometime this summer.
Now, can you expound on how we can support you this summer on this initiative? What can we do to support the public comment on the proposed waiver renewal?
Mm-hmm. So I think a lot of it it'll be led by our organization, and I think it's going to be a collective effort within our organization or within our coalition on what exactly we're reacting to, because we don't really know what is going to be in Mass Health's waiver application to CMS. We hope that they're going to apply for expanded or extended flexible services program, in which case all of us together as a coalition are going to analyze what's in that waiver application and say bravo or say like, no, we want to see more support for these services within the waiver. So at the end of my presentation, I'll sort of get into about how to get involved with FIMMA, but that's sort of to give you an idea of the type of work that our coalition does together. It's a lot of people who have very direct experience with working in healthcare or working for social service organizations that provide nutrition supports. But that also doesn't mean that there isn't a role for people who don't work in those fields directly. So there's still some work for general advocacy as well. Any other questions? Okay, so this is diving into some of the work that our coalition does on a task force level. So we're focusing on having better nutrition education within healthcare provider education. So basically, how much nutrition education is provided in medical school? Very little. So we're advocating to change that. So one of the things that the very unfortunately abbreviated PNER task force, which is Provider Nutrition Education and Referral Task Force, they developed a list of nutrition core competencies, and this list is like very comprehensive. And they are working now to reach out to deans of medical schools within the Boston area and start to get this to their attention to possibly incorporate this within the medical school education. And this is just what they're working on this year, but also working beyond that of perhaps not just medical school, but dental school, other types of healthcare provider education, such as nurses or social workers, anything that is related to being a healthcare provider. And perhaps also not just in their primary education, but also in continuing education. Our research task force, their main goal is to support and disseminate food as medicine research. So there's other kind of three ways that they work on this. One is to, they actually do a lot of work for advocacy and helping create materials and collaborating on the messaging for certain policy opportunities. So, since policy is so often driven by what the research shows, their work in helping shape those messages is really important. So they also develop resources that are more general for increasing awareness of food as medicine research. This screenshot is they've published a pretty exhaustive list of all of the peer-reviewed research in the US that looks at food as medicine services. And it's in, just kind of handy tables that really outline what the research shows. And also they just kind of work as a task force to network, so expanding and strengthening their research networks. Food research and healthcare research can often be very disparate, so that's a big part of networking is a pretty important goal or component of this task force. So lastly, the community-based organization task force. The CBO Task Force main goal is to expand equitable access to community-based services. And so the three things that the CBO Task Force is working on, one is diversity, equity, inclusion, or DEI, and community engagement. So with that, we're working to improve the DEI basically of FIMMA itself as a coalition. But we're also looking to have much more increased engagement and advocacy from the people who receive these services directly. So this, image on the right is a flyer for an event that we would hold for just basically being an open session for individuals with a direct experience of food as medicine services or direct experience of food insecurity and chronic disease. To really educate them about what FIMMA does, but also understand more about how they view their experiences and how they view food as medicine. The CBO Task Force is also working on providing some technical assistance for the coalition and perhaps more broadly. So this might mean a webinar on how an organization can best adhere to HIPAA laws. So within, as I mentioned, we develop program standards and the CBO Task Force, or the purpose of this technical assistance is to help organizations kind of reach those program standards. And lastly, as the inventory is being developed, we get lots of questions about the definitions themselves, as the programs are going to fit into the inventory according to which program definition they fall into. So the CBO Task Force is sort of constantly looking at our definitions and standards and considering where clarifications might be needed. Any questions about those projects or activities? So how to get involved. So I think there are, these are my very general ideas for how to get involved, because I wasn't sure exactly who was going to be joining tonight. But the first one being to join the FIMMA mailing list. So through the FIMMA mailing list, you'll get general updates on some of our coalition-wide activities, such as what's happening with the inventory, as well as any sort of advocacy alerts or opportunities. So that might be something like, hey, here's the day where we're all going to contact our legislators and advocate for the food as medicine pilot bill. And we also have quarterly coalition meetings. So the FIMMA mailing list will inform everyone about that. And you can sign up for the FIMMA mailing list by going to foodismedicinema.org. And that also just has lots of resources. Some of them I mentioned before, if you're interested in learning more about any of this. So also the second biggest thing is to really get to know these organizations, or the food as medicine organizations, directly by volunteering. So within our website, it has a list of all of our member organizations throughout the state. So I know that, most of you are probably Boston based, but that list of organizations is a pretty comprehensive one for organizations that accept volunteers, and is a really great way to get to know the type of work that we do. And I'll put in a plug just to volunteer with community servings, because I'm here from community servings. So our kitchen is in Jamaica Plain, where we prepare all of the meals for all of our clients from scratch. That's something that a lot of people don't know about what we do, is that everything is made from scratch, and is really also very good food. So we host group and individual volunteers to prepare and package meals for our clients. And I will also put in a plug for our young leaders, our community servings young leaders, or SIZZLE program. And so this is a group of young professionals who really work to advocate for our mission. That might be by hosting volunteer nights, or organizing fundraising events or educational events throughout the year. So, this is just sort of what community servings provides, but I'm sure that there are plenty of other organizations that are members of FIMMA that also have really great volunteer experiences. So I encourage you all to check that out. All right, so I guess that's the end of my presentation, but happy to take any questions.
Feel free to take yourself off mute if you have any questions, or if you want to put them in the chat, I can ask Hannah for you. Okay, so any questions? If not, thank you, Hannah. This was incredible.
Yeah, thank you very much. I hope it was informative.
Very informative. And then I did get a couple questions. Are you able to share the slideshow with us, or?
Yep, absolutely.
Okay, perfect. That's great. So then we can share it to our wider audience. And then, Sarah, do you have anything else to add?
Yes, thank you so much for joining us, Hannah. This has been absolutely terrific, and we look forward to identifying ways to continue to support your efforts.
Yeah, thank you very much, everyone.
Thanks again, Hannah, and thanks everyone for joining us tonight. Have a great night, everyone.